I'm a consultant radiographer. I've been a consultant for nearly 9 years. And basically my role is very similar to that of the radiologist. So basically patient care is the most important part of my role, and that can vary depending on the clinics I'm working at. My main job is image interpretation, both X-ray and ultrasound, taking biopsies, making a diagnosis with the patient I'm seeing, and also it involves going to multidisciplinary team meetings where the whole team can make an accurate assessment of each patient with care and accuracy. The team meeting is absolutely crucial. It's where it all comes together.
Very good. And how would you describe, your primary responsibilities or your primary goals that you're working towards, that you're given? Can you describe what those are?
Well, the goals are to make sure that each patient is accurately assessed, and if they have to be reassured and discharged, to be given with care and to teach them or educate them about different things that can happen with breast problems. I think it's important when people come that if we do reassure and discharge them, they go away with some knowledge about what is normal or what might not be normal. The other thing is that if you have to do further diagnoses, so to be able to give what we feel is the diagnosis with empathy and care, I think that's absolutely essential. To me, each patient has to be an individual. It's the way I would like to be treated if I were a patient, and I think that's crucial. But the basic role is that each patient gets the care they need and the time they need.
What are the things that you've put in place in the department in order to achieve some of those things, like treating the patient as an individual, like making sure that they're given a timely and accurate diagnosis?
As the clinics have increased, as you know, we have the 2-week wait, which puts a lot of stress on the department. Instead of just having 2 clinicians in the clinic, in the symptomatic clinics we have 3. So that means that there are enough people there to look after each patient, and we have sufficient help within the clinic with either other radiographers or with the clinic helps, and that helps the patients to flow through the clinic. If obviously we cannot fit them all in, we then have rollover clinics where we put extras in. Ideally, we like to do a one-stop clinic because the patient is obviously very anxious when they come for a symptomatic clinic, and we'd like to do it all on one day so they don't have to visit again. So with that in mind, we have 3 ultrasound rooms, we have 2 X-ray rooms. What we try to do if they need extra, like stereotactic biopsies, we obviously are not able to fit those in the clinic. So what we do now, we've 2 clinics where we fit in these extras so that they're done as timely as possible, because these women, they want a result as quickly as possible. They don't want to be hanging around. They're anxious. Perhaps at the end of it everything is fine, which is great, but we don't want to prolong their wait because it's very scary.
And what do you have to do in that time?
Well, basically the 2-week wait is when one visits the doctor, they have a problem. They are referred to the symptomatic clinic where they will see the surgeon. And that has to be done within 2-week wait. That is government guidelines. It has to be done. So they receive an appointment, they come to the clinic, they'll see the surgeon, they'll send them down for imaging. Depending on their age, they will have mammography, plus or minus ultrasound. Generally, most women have ultrasound. Women under 40 have ultrasound only, unless, of course, we see something on ultrasound, which as clinicians worries us. Then, if they need a biopsy, they will receive an appointment to go back. It has to be done within 2 weeks. And then the treatment it's the 31-day. They have to receive treatment within 30 days of diagnosis. That is government guidelines, which puts a lot of pressure on clinics because the women are more aware today in some ways, and so therefore they present much quicker, and general practitioners also refer them, because in the past some of the waits were 6 weeks for an appointment, in which case they had some cancers in the 6 weeks, and this is to prevent that happening.
So are there key changes that you've made to your service in order to achieve the 2-week wait and the 31-day, for treatment? Are there key changes that you've made, key things you've implemented over time to achieve that?
Well, obviously we've tried to find more time and space. We now have 3 clinicians in a symptomatic clinic, and so that makes a big difference. We have tried to, rather than have 3 smaller clinics, we tend to have 2 big clinics now, with anything up to 50 new appointments on a Tuesday morning and a Friday morning. And ideally we try to see all the women in that time. We strive very hard to make sure they're fitted in that time.
Are there any other specific measures, like the 2-week wait, 31 days? Are there any other specific measures that you are aware of being measured on or needing to achieve?
We are constantly audited through the National Health Breast Screening Programme. Every year we're constantly audited on the number of films we read and our recall rate, whether we have too many false positives. We also look at the false negatives in the interval audit. And also, to comply with the National Health Screening Programme, we actually now have 2 clinicians in each assessment clinic, and that is where the women are recalled for, they've been for screening, we've seen something we're not happy with, and we have 2 clinicians in each clinic. And the idea is that if we, for example, reassure and discharge a patient, that both clinicians are happy to do that. So that is a safeguard, rather than send them away and then review it and find that perhaps people aren't quite happy with sending the patient away. So that has been very helpful. So everybody's happy. We work very much as a team, and that has been something we have implemented, as well as courses or the constant auditing. We all partake in performs twice a year. So that is a set of senior radiologists will have a set of images. We have to read them blind, and they look at our recall rate, our return to recall, our normal routine recall, and we are audited on how well we performed, and if we fall outside what we call general parameters, they sometimes would ask you to retake the test again, and it's done twice a year to make sure we are hopefully working at peak performance.
Are there specific things that you're doing or measured upon to sort of, in terms of patient satisfaction? Is there any?
Yes, we do patient satisfaction questionnaires. We also have a 360 appraisal where your team will fill in a form and see how they feel you're performing. They also ask patients. Obviously, as a clinician, you won't know who they're asking. So that is one way of reviewing how each clinician works. Yes, so we do patient satisfaction questionnaires. And then also we get feedback. Women we've seen who then go for the results at clinic, we often get feedback through the breast care nurses. Oh, they thought you were great, or whatever, So we do get very much feedback. I think it's very important.
Mm. And as a consultant radiographer, what are the things that keep you awake at night?
Sometimes if you think you've got it wrong, or perhaps you didn't handle a case very well. I mean, we do get sometimes very aggressive patients. Generally speaking, not, because they're so nervous. But sometimes you feel you haven't handled something as well as you should. Or perhaps when you go to the multidisciplinary team meeting, you'll find a case and someone will say, well, you've assessed this, but we're not quite happy with it. And you feel, oh, did I give that the care and attention I should? Yes, I think if you feel you haven't done very well in looking after a patient, that's something that will keep me awake at night, or if I thought I hadn't got it quite right. It is a huge responsibility, but it's to give it your whole heart and soul.
What are the things that have happened that make you feel really good?
Sometimes when a patient just says, oh, you've been lovely. You shouldn't have to have that, but it is nice because you feel you've given them something very positive. I feel as if I were a patient, I would like to feel the person who is dealing with me treated me as an individual, just not like on a conveyor belt. To me, that is absolutely crucial. I try my very best to treat someone as an individual. I like people, so working with them as a consultant, which is something I never thought would ever happen to me, is a privilege. I feel very privileged to have the job I have. And years ago, it wouldn't have been thought of. But with the shortage of radiologists and with the skill mix, I'm very fortunate to have this role.
The magic one question is, if there's one thing that you could change or add that you feel would make the biggest difference to your job, what would that be?
Our department is very small. We feel as if we've been pushed into a shoebox. It would be nice to have a really purpose-built breast department where the surgeons, the radiology, could all be under one roof, where the patients didn't have to come from outpatients up to us, and where we could have a bit more comfort for the patients. I mean, it's not bad, let's be honest. It would be nice to have a purpose-built department. Yeah, that would be the magic wand, really, and to have all the care that they need, like the holistic care that they can give. You know, it could all be under one roof, and probably more time, but there's only 24 hours in the day. I can't see that happening.